We'll go on to Dr. Ramanjit Sihota. She is going to summarize a really complex problem, as you have seen with all the talks so far.
No.
No.
Audio.
Hello?
You are audible,
Yeah.
ma'am.
So I think the main thing whenever you're treating anybody is to understand what you're treating. And everybody has an opinion. Everybody has an opinion as to what to do, especially in angle closure disease. Primary angle closure disease isn't a single disease at all. So if we look at it, we know that there's an entire spectrum. So you could call PAC a person who has one synechiae. You could call PAC a person who has 180 degrees of synechiae. You could call PAC somebody who has a 0.3 cup. You could call somebody who has a 0.7 cup, but without a visual field effect PAC as well. So I think first we need better definitions, but with what we have, the classification that is currently propounded by the World Glaucoma Association was initially for surveys, and I would say to you that we need to understand what happens in eyes, and that may not be significant clinically. So if you look at what happens in patients who have just the anatomy, you know, as everybody has talked about, that largely we see pupillary blocks, but in about sort of 8 to 20%, we have plateau irises, we have exaggerated lens vault at about 7 to 24%, and a prominent last roll. But are we treating the anatomy, or are we trying to see which patients are likely to develop ITC or pass in the future, or have trabecular dysfunction? So when we looked at the ZAP studies that you've already been told about, at 14 years, what we heard was that it decreased the progression to primary angle closure by 66%. What we didn't hear was that they actually excluded all the patients who were anyway high risk for angle closure. So if you actually put that in, you can say that the iridotomies are definitely very safe, as has been proved by the Singapore study and by the ZAP study, and they significantly reduce the progression. And keep thinking that your patients come to you when they are 40, 45 years old, and they are now going to live to 80 or 90. So even if you can reduce the progression to PAC, it is significant for that particular patient. What about iridotomies? What are we hoping to gain from an iridotomy? One is that it widens the angle, and more importantly, what happens is that the IOP fluctuation, because of mild subacute attacks, is actually reduced as well. And again, I would say it's safe, so please think of treating even anatomy, because we know these progress, and especially if there are people who have PAC or PACG in the other eye, don't forget to do an iridotomy in the fellow eye. People with a family history and a very narrow angle, please think about doing an iridotomy. Patients requiring frequent dilation or staying very far away from accessible health care are also indicators for iridotomy when only the narrow angles, that means a primary angle closure suspect, comes to you. What happens after you have sort of moved on and the patient next comes to you, and you can see either a single synechiae or you see blotchy pigment, as Shri Sirisha also pointed out, these sort of isolated pigments that you can see, or you start seeing actual synechiae or a completely closed angle. So now we have moved on to where the gonioscopy, if we do it well, is actually telling us what's happening in the trabecular meshwork. The trabecular meshwork over time, the first picture here is of primary angle closure suspects with wide open angles, so the aqueous can flow through. Here we have acute and subacute angles, and here we have a chronic angle closure glaucoma. So when we actually see that we could have done an iridotomy at this point, either as a PSCS or as a PSC, we can actually aim to prevent progression to trabecular damage, because trabecular damage is happening because of repeated iridocorneal contact, and also your patients are getting older, so there is age-related changes in the trabecular meshwork. So why should we treat one single pass? If you see one single pass, should we be thinking of treating, doing an iridotomy? And I say yes, because we know that at least about 30% or more are going to progress over time to develop a primary angle closure glaucoma. And which eyes are most likely? Those with very narrow angles, a lens thickness which is more than normal, and those who already have PAS of more than 2 quadrants. So if you want to treat PAS, please think that the reason you're doing it is to prevent further occlusions, further PAS that is occurring. So we do an iridotomy, 2 or 3 weeks later, do a diurnal phasing. Make sure your IOPs are sort of in the range of 14 to 17. Rule out anything else like a plateau iris or a lens. Do a baseline perimetry and imaging and review every 6 months. Phaco is considered to be equivalent to an iridotomy as per the EAGLE study and a lot of the talks you would have heard of. So what are we hoping to do with the phaco in primary angle closure disease? The first one is this beautiful cosmetic appearance of the iris that falls back. But what are we doing to all these kind of things that are there in the trabecular meshwork? It is suggested that some effect of the phaco may be partly the ultrasound, which is actually washing out some of the debris. The IOP has been seen to fall 2 to 8 millimeters, but this is largest in patients with acute angle closure, and all of you have seen acute angle closure comes with pressures of 50, 60, you wait, you do an iridotomy, and patients come back with pressures of 14 and 16. So what the additional benefit of the phaco in acute angle closure may just be the fact that the angle has been reopened. EAGLE study, the authors themselves had said this difference of 1.18 millimeters is small and by itself is unlikely to be clinically significant. So do not use clear lens extraction instead of a laser iridotomy because the difference, at least for those 3 years, was not significant. But we do know that over time, patients are getting older, there is trabecular damage, the pressure is going to rise. And the raised pressure, as we already know from ocular hypertension and other studies, is what leads to the glaucomatous optic neuropathy. So please, if you see an IOP of 20 or 21 in primary angle closure, please treat them. Acute angle closure, I think we're all aware that over time, 20 to 30%, whether you do a lens extraction, an iridotomy or medication, will develop glaucomatous optic neuropathy. As far as the primary angle closure glaucoma is concerned, I would like to tell you that in these cases, the IOP is much higher. When we start, the progression occurs earlier, it worsens faster than in patients with POAG. So please do a laser iridotomy and lower the IOP to target IOPs. What is the role of iridotomy in PACG? As you can see here, in the first picture, the ITC was 100%, and you can see how high the iridocorneal contact was. After the iridotomy, the height of this contact to the trabecular meshwork has fallen, and many areas of the trabecular meshwork that were actually sort of being obscured by the iris are now able to function. Keep your IOPs to target IOP, early defects 15 to 17 millimeters, moderate 12 to 15, and severe 10 to 12. If you can do this, the PACG progression in 10 years is 1 to 2%. Trabeculectomies by many studies have shown that it is very safe, especially when you use releasable sutures. What is the role of cataract surgery in PACG? Many meta-analyses have shown that they actually have some effect, but not significant, and medications still need to be continued in many patients. Somebody was talking about goniosyneculalysis. That also, there's a meta-analysis which has shown that in PACG, goniosyneculalysis has no significant difference in terms of IOP. But what are the visual changes after cataract surgeries? A lot of people lose vision because it's a complicated surgery in a very narrow anterior chamber depth. We know that PACG can progress even after lens extraction, and people sometimes don't go back for a regular review. A lot of people also say that if the AC is very shallow, 2 millimeters, 2.5 millimeters, then a lens extraction is probably going to help. But actually, there is no cutoff that has been actually said that at this point you start needing to do a phaco trab rather than a trab. Releasable sutures has made our lives much, much better. And every meta-analysis says that the addition of a trab to a phaco lowers the IOP much more, reduces all the problems that you're likely to have. Just this last 2 slides, one says that the narrower the angle, raised IOP, the extent of the pass is what actually tells you how your patient is going to progress further. And after that, don't forget that ischemic heart disease, steroid use, IOP fluctuations, just as in PACG, continue to happen in our PACG patients. I think he's taken away my last slide, but that basically was that you can prevent primary angle closure glaucoma and visual field loss if you treat at least all PACs. Even if you see one synechia, do an iridotomy, you have done that patient a favor, and for the rest of her life or his life, this may not progress to a point where they actually go blind, which is what most of our patients that we see present with these days. Thank you.
Thank you, Dr. Ramanjit. That was a very nice summary of management of a very